Good evening, everyone. My name is Dr. Eric Ball. I'm a primary care pediatrician from the CHOC Primary Care Network in Orange County, and I'm here today with Dr. Pia Panaraj, who is an infectious disease physician at the Children's Hospital of Los Angeles. And we are co-chairs of the Emerging Issues Committee of the California Immunization Coalition, and we will serve as moderators for today's conversation. Thank you for all joining our very first COVID Conversations webinar. We are overwhelmed by the response to this series. We've had over 500 people register and over 200 questions submitted during registration. And there's clearly a lot of interest in the upcoming COVID vaccines. And we'll do our best to continue these webinars to educate our California community until they're no longer necessary. We have two fantastic speakers on tap for tonight, Dr. Bonnie Maldonado and Dr. Peter Szilagyi. Both were members of the California, I guess now Western States, COVID-19 Vaccine Scientific Safety Review Work Group that will review the safety of the COVID-19 vaccines for California, as well as the states of Washington, Oregon, and Nevada. So just a brief overview of what we're going to be doing today. So this will be a webinar format, so all of your lines are automatically muted during the duration. We will have question and answer periods for each speaker. So there's a question box that you can enter your questions during the conversation. Each panelist will speak for about 15 minutes, and then we'll have 15 more minutes of questions. And we will record this webinar and post it on the CIC website, as well as on our YouTube page if you want to see it later, or if you have colleagues who missed it tonight. Next. So if you have any technical difficulties in the chat box right now, Cameron has supplied a help desk, so you can contact those people if you have any concerns, or you can give us a call at CIC at the number listed below. Next. Here's where your question, each of you has a GoToWebinar control panel with a question panel, and you can enter your questions there, and then we will answer them after all of our questions. If you have any further questions after the presentation, you can email to us at the CIC, and we can get them to the presenters in the future. So this webinar series is being brought to you through the California Immunization Coalition in partnership with the American Academy of Pediatrics California. So CIC is a nonprofit, private-public partnership dedicated to achieving and maintaining full immunization protection for all Californians to promote health and prevent serious illness, disability, and death. And this webinar series is a brainchild of our Emerging Issues Committee, and the COVID-19 vaccine is probably the most emerging issues in vaccinology in a long time. And we want to thank our CIC staff, Catherine Martin and Cameron Saylor, who are behind the scenes and have done all the hard work to put this on. We're also co-sponsored by the American Academy of Pediatrics California. This is a partnership of the 4 local AAP chapters in California. So chapter 1 is Northern California, chapter 2 is Los Angeles and the counties surrounding it, chapter 3 is San Diego and Imperial counties, and chapter 4 is Orange counties. So if you're on this call and you're a pediatrician, please make sure you're a member of your local chapter so that we can continue to put on events such as this one. So here's some save the dates for some future conversations we have in store. So we are committed to continuing this webinar series until there's a point where we could all safely gather together and listen to these things in person. But at that point, we won't need to do it anymore. So our next one will be Wednesday, January 13th at 6 p.m. And we'll be having the co-chairs of the COVID-19 vaccine drafting guidelines work group. These are the people who are going to deal mainly with logistics and allocation issues. Dr. Oliver Brooks, who is the CMO of Watts Healthcare, and Dr. Rob Schechter, who's the branch chief of the California Department of Public Health Immunization Branch. And then save the date February 8th at noon, it would be an earlier one. We're going to have Dr. Peter Hotez, who is very well-known founding dean of the National School of Tropical Medicine at Baylor. And he'll be talking about COVID vaccine hesitancy and combating misinformation. Next. So we're going to start each of these talks with the COVID vaccine guiding principles that the state has put forth. And I think this is something that will be the overriding theme for all of these conversations. So California distribution of COVID-19 vaccines will be guided by the following overarching principles. The vaccine meets safety requirements, is distributed and administered equitably, people at the highest risk of infection will get the vaccine first, and community stakeholders are brought in from the outside for transparency. And with that, I'm going to turn this over to Dr. Panaraj to introduce our first speaker.
Great.
Oh, that's us.
Oh. Well, we can introduce ourselves too. Hi, I'm Pia Panaraj, and I'm at Children's Hospital Los Angeles. And then you heard Dr. Ball as a primary care pediatrician with the CHOC Primary Care Network. All right, so I have the pleasure of introducing Dr. Mani Baldonado. The hard part about introducing her is going through all of the amazing things that she's done and trying to just condense that into a couple of sentences. She is a professor and chief of the Division of Infectious Disease in the Department of Pediatrics at Stanford University. And she's also the Senior Associate Dean for Faculty Development and Diversity at Stanford. She's led a number of NIH, CDC, USAID, Gates Foundation, and WHO-funded domestic and international pediatric vaccine studies. And with the onset of COVID-19, she has over 10 clinical, epidemiologic, and laboratory-based studies in this area. And, you know, COVID-19, it's been less than a year. So she's a liaison to the USPHS Advisory Committee on Immunization Practices, ACIP. And both of our speakers tonight are on the Scientific Safety Review Work Group that was appointed by Governor Newsom for COVID-19. So with that, Bonnie will share her slides.
Thank you so much, Pia, for that introduction. And I'm going to switch my slides over here. And so thank you for having me today. I'm going to talk a little bit about an update on COVID vaccines. I'm also I think one of my proudest accomplishments, other than my 3 kids and my family overall, is the fact that I am the chair of the Committee on Infectious Diseases for the AAP, or the Red Book Committee. It has been such a pleasure and an honor to serve the Academy and to work with all of the wonderful people at the Academy and all of the members of the committee on vaccine policy and infectious disease policy. And it has been one of the highlights of my career. So I've learned so much from that group of experts. And so it's really been a great help for us in trying to understand what to do with this incredible pandemic. So I want to just go over the next 10 or 15 minutes some data around the vaccines, and Dr. Szilagyi will really go more in depth into some more of the processes that will be taking place as we start to evaluate these vaccines and provide implementation. So let me see if I can get this to work here. Oh, there we go. So for those of you who are not yet familiar with this famous spike protein, the coronaviruses are enveloped single positive stranded RNA viruses, and they have a nucleocapsid in the middle here. So they're RNA viruses. They're actually large RNA viruses with a protein coat. And fortunately for us, we think that there's one major protein on the surface called the spike protein, for which immunity appears to be protective against infection. There are other proteins, the envelope protein, for example, and the M protein, but we do think that spike protein elicits neutralizing antibodies that are protective against infection. Now, this virus is a member of the human coronavirus family, of which there are 7 known viruses. 4 of them are endemic viruses, which cause normal seasonal colds, but the other 3 are SARS, MERS, and SARS-CoV-2. And so clearly we know that we're seeing new emerging pathogens from the coronavirus family. And so just the reason I show you this slide is so you understand that this came from a normal cold virus family. It's likely a mutation from a bat virus into an unknown intermediate animal host, and then further attenuated so that this spike protein actually can attach to the ACE2, which is a receptor on many human cells, notably those in the respiratory tract. And so this virus has now able to attach to that ACE2 and proliferate and cause the symptoms that we have seen in the last year. So when we look at targets of therapy, I'm just going to briefly mention that vaccines are not the only, they are not the only ways that we're trying to deal with this virus. Clearly, here's a cartoon of the virus itself, and you can see that if we direct antibodies to this virus, and we have done this so far in the laboratory and in humans and animals, we know that, as I mentioned, antibodies to these particular spikes, areas of the spikes, and in particular to the RBD, or the receptor binding domain, can actually block infection or attachment of these viruses to the human cell. And so you can make antibodies passively, either through convalescent plasma, infusion of convalescent plasma, or infusion of monoclonal antibodies, or you can make active immunity through vaccines. And that's what we're going to talk about today. But you can see that here is where attachment occurs, and there's also other mechanisms for which antivirals are being used. So for example, there's another receptor called TMPRSS2, which is the it's a protease that's on the surface of the cell, and Camostat is an antiviral that has been used for other diseases and is also thought to be able to block attachment of the virus to this other receptor, this TMPRSS2 receptor. And then we see that there are a number of pathways once the virus enters into the cell, for which we think that eventually we'll be able to develop antivirals mechanisms to stop replication. So for example, here is another antiviral that we're studying here at Stanford and other places as well, called favipiravir, which blocks the protease, is a protease inhibitor and blocks viral replication. Remdesivir is a nucleoside analog and also prevents replication and transcription of the virus. But today we're going to focus on the vaccines because these are preventive, and all of these other treatments so far we think will actually treat active disease. And so it's always, as pediatricians, we know that vaccines and prevention are better than trying to wait for disease and trying to develop a treatment or a cure. Now, if for all of you who are interested, the New York Times has the best graphics of many of the current sources of good data, and they do have a coronavirus tracker. And in that tracker, it'll tell you all of the different vaccines that might be available and what phase of trials they are in and what they look like. And it's a really nice way to keep up to date. Now, at this point, we have over 200 COVID-19 vaccines that are currently under development around the world. But as we know, there are actually 6 vaccines. The slide is produced last week, so now it's out of date. But there are now 6 vaccines that we will be evaluating in the US. 4 of them are in phase 3 clinical trials, and 2 more vaccines will be in phase 3 clinical trials here in the US in the coming early 2021. And so I want to focus primarily on the 2 that we have all been hearing about. That is the Pfizer-BioNTech vaccine and the Moderna vaccine, because these are not only already submitted to the FDA for review and potential approval, one of them tomorrow and the other next week, but these are also unique vaccine platforms because they utilize mRNA or mRNA from the virus that looks, it's a sequence from the virus that codes for the spike protein that I told you about. And these vaccines actually are comprised of actual mRNA that can then go into the cells, can then replicate, cause replication and development of just the spike protein itself. So it doesn't produce live virus at all, it produces spike protein, and then you can make an immune response to that. And so far, the Pfizer vaccine has been studied in 44,000 individuals and the Moderna vaccine in about 30,000 individuals. And I'll show you the data regarding the outcomes so far, but just the bottom line is the Pfizer-BioNTech vaccine appears to be 95% effective 7 days after the second dose, and is equally effective in older adults and by gender and by comorbidity. And similarly, we don't have as much data yet on Moderna, but we will have more in the next week. And this vaccine has also been demonstrated to have almost 95% efficacy as well across many populations. So the Pfizer vaccine was submitted November 20th to the FDA for review, and the Moderna vaccine was submitted 10 days later on November 30th is for review. And so tomorrow the FDA will have an all-day meeting to review the Pfizer vaccine and make their recommendations to the FDA. The FDA Vaccine Advisory Committee will review this vaccine and make their recommendations to the FDA leadership. And then 1 week later, they will review the Moderna vaccine and do the same thing. And then Dr. Szilagyi can tell you what the next steps will be. So when you look at the Pfizer-BioNTech vaccine, you can see here, this is really the bottom line regarding this vaccine. So I mentioned that there were over 44,000 people who were enrolled in this trial, but about 36,000 of them were included in this particular analysis, looking at a randomization to vaccine or to placebo. And you can see here that overall, there were 170 cases of disease. So this was actually symptomatic COVID disease, not infection, but symptomatic disease. And you can see that 8 of those cases occurred in vaccine recipients and 162 cases occurred in placebo recipients. And this translates out to 95% vaccine efficacy with pretty tight confidence intervals of between 90 and 97% efficacy. Now, when you break it up into age groups from 16 to 55 versus greater than 55 years of age, you can see that the distribution of cases between vaccine and placebo recipients was similar, with very high efficacy as well. And this is actually my favorite slide. Oops, and it just disappeared. This is my favorite slide, and what this shows is the number of cases over time after dose 1. And this is I should mention, this is a 2-dose vaccine that is given 21 days apart, at least it was in the study. And so you can see here, this is day 0 after vaccine administration over time. And the red dots, the red squares indicate numbers of cases in the placebo group, and the blue line indicates numbers of cases in the vaccine recipients. And you can see that pretty much around day 10 or so, you really started to see a major drop-off in cases in the vaccine recipients. And some of my immunology colleagues like to point out that this seems to indicate that the immune response occurs very early on. So B cells really seem to kick in at around 10 to 12 days after vaccination, which is just what they're supposed to do according to the textbooks. So very good news indeed. And if you look at the data from the FDA and Pfizer, the 1-dose efficacy is about 52%. So still pretty good efficacy after 1 dose, but clearly 95% is much better. This is just, I don't want to really focus on any of the details here, but just to show you that there's a large body of safety data, because clearly we want to make sure that safety is the primary endpoint for any vaccine, especially for the general population. And you can see that when you compare the vaccine group to the placebo group, there are no significant differences between the 2 groups in any of the adverse events. Injection site reactions were obviously higher, however, in the vaccine group. And of course, systemic adverse events were higher in the vaccine group compared to the placebo group. But the main thing to note here is that the adverse events were identical statistically in the 2 groups. This is just, so moving on from the Pfizer vaccine, which we will hear more about in the coming days, These are the 6 vaccines that we are being studied in the US or will soon be. So the Moderna and the Pfizer are being reviewed soon. Or the AstraZeneca vaccine is being studied around the world and the US. The Johnson & Johnson vaccine is being studied in the US as well. And the Novavax and Sanofi vaccines will be studied in early 2021. Fine, I won't spend much time here because Dr. Szilagyi will be talking about the proposed phase 1 vaccine rollout. This has been voted on by the CDC ACIP, and the idea will be that the first phase, or phase 1A, will be a vaccination of healthcare personnel and long-term care facility residents around the country, followed by phase 1B, essential workers, and phase 1C, adults with high-risk medical conditions and those over 65. You'll hear more from Dr. Szilagyi. And then, of course, these are the definitions of those groups. Just so you know, they are pretty closely and carefully defined, and Dr. Szilagyi, again, will talk about these in a little more detail. So what's next? As I mentioned, the EUA filing occurred, and tomorrow and next Thursday, tomorrow the Pfizer vaccine will be reviewed, and then if that is, those recommendations will go to the FDA, and if approval is issued, probably as an EUA, then the CDC ACIP group will review those recommendations over the weekend. And then here in California, Dr. Szilagyi and I will be involved with reviewing those reviews over the weekend as well, we hope, leading to potentially rapid deployment of vaccines as early as next week. And then the week after, so the week of, so starting on December 17th, the same process will happen for the Moderna vaccine. So we're anticipating that there will be large numbers of doses available for all healthcare workers in the country within a week or so, and that by the end of January, there should be vaccine for all healthcare workers and long-term care facility residents. Now, this is the phasing of the vaccine over time. Obviously, we'll need to ramp up production, but over the early part of 2021 and into the spring, we anticipate large numbers of doses will be available for many populations, and then anticipate continued vaccination over time. And then finally, I just want to mention that in this global scramble for coronavirus vaccines, we can see that we need to be careful about equitable distribution, not only in the state, but all around the world. And you can see here that because many of the Western countries have had access to purchasing vaccine early, it is anticipated that most people will need 2 doses of vaccine. And here you can see that the UK, in theory, will have up to 5 doses per capita for their population. And the US, the European Union, and Japan will have at least 2 doses or enough doses for everybody in their populations. But many other countries and regions of the world will not have such access. And so we really want to encourage the manufacturers and governments around the world to make sure that these vaccines are available in an equitable fashion to all populations, including children around the world. And so I will stop there and move back to our moderators. Thank you so much.
Wonderful. Thank you very much for that. We had many questions coming in our question and answer chat box. And also, even before registration, we had nearly 700 people registered for this webinar and received over 200 questions just at registration. So I will ask you some of those. So there are many questions about the mRNA vaccine. Will you please tell us about the history, mechanism, and any long-term safety data on mRNA vaccines?
Yes, so that's a great question. And as you all may know, the mRNA vaccine platform is a new platform. There has never been an mRNA vaccine that has been licensed for use. But these are small segments of genome of RNA, of nucleic acid. And this particular mRNA platform really codes for the certain regions of the spike protein. and they will incorporate into the human genome, but there is no data to suggest that there are any, for example, bystander safety effects due to integration into the host genome at this point, and that's been shown in animals as well as in humans so far. But certainly long term, we will need to follow studies of large numbers of individuals to see how well this platform holds up in terms of safety, as we do for any other vaccine. And it is an exciting platform. Now, I will mention as well that one of the reasons why the mRNA platform seemed to move very quickly was not only because there were a lot of resources and funds available, but also because it is much easier and safe to make a safe mRNA platform, because you're really just taking small pieces of nucleic acid and amplifying those for production purposes, whereas making protein subunit vaccines requires usually either viral vectors or other vectors in order to produce large batches of product to test in animals in the laboratory as well as in human trials. So this platform, if it works, could be a prototype for other vaccine candidates as well.
Great, thank you. Can you comment on differences between the two leading vaccine candidates?
At this point, I don't know enough about the Moderna product to really say that there probably are differences in the way they're manufactured. Clearly, we know that the Moderna vaccine does not require the ultra freeze temperatures that the Pfizer product does. So currently the Pfizer vaccine requires minus 70 degrees long-term storage temperatures, and the reason both of them require cold is because their RNA is very fragile and unstable, and so it needs to be kept at very cold temperatures prior to use so that it doesn't degrade. And the Moderna vaccine, on the other hand, requires minus 20 degree storage for longer periods, which is obviously much easier to achieve, although still not simple. So both companies are actually working on trying to develop products that will not require this degree of cold temperature storage or cold chain.
What other COVID vaccines show promise, and how do we decide for our staff and patients?
Right, so you saw that there are over 200 candidates now, but the 6 that we are focusing on are the 2 mRNA vaccines, the Janssen and the Janssen and let me think, what's the other one now? The AstraZeneca. Sorry about that. I had a little slip. Those are adenovirus platform vaccines, and those appear to be safe and effective as well. And then the other platform is the protein subunit vaccine. So those are the traditional protein subunits that we are all familiar with, such as, say, the hepatitis B vaccine, etc. The one thing, those are the Novavax and the Sanofi vaccines. Now, the Sanofi product is also a nanoparticle vaccine. So it's actually, the antigen is embedded in nanoparticles. So the idea is that you get more surface area of antigen, so you can express more antigen for immune responses. Now, at this time, it appears that they are all quite safe, and we will have to see phase 1 and 2 data on the protein subunit vaccines, that is the Novavax and Sanofi products, before we know how effective they are. And the Janssen and AstraZeneca products are still in trials to demonstrate their own efficacy as well. But at this point, it's been surprising how low the safety signal, that is how good the safety signal has been for these 6 candidates. And there are others coming down the line, many other that are still in the process of phase 1 to development. So I do think that the best way to judge which vaccines will be safe and effective will really be to look at the FDA and ACIP guidance. And of course, I'm partial to the Red Book Committee and the AAP, but the AAP does work in very close collaboration with ACIP and CDC. We have regular calls with CDC, and our AAP leadership is committed to harmonizing as much as possible with CDC and ACIP guidelines. So I would depend on our usual sources for vaccine information to decide which vaccines to use. Now, if you're looking at vaccines for adults, which we generally don't as pediatricians have to do, the other place that I would look to is the Infectious Disease Society of America, or the IDSA. They also put out a very strong and very evidence-based guidelines as well for providers and for the infectious disease community. And so we frequently will make recommendations based on the evidence that is available.
How long will the COVID-19 vaccine immunity last, and will we need repeat doses each season?
That's a really great question, and unfortunately, we don't know the answer to that. So two things. Number one is we don't understand the duration of immunity. We don't understand the degree of immunity. So as I mentioned, these studies were very large studies enrolling almost 75,000 people for the two vaccines, but they did not track infection. They tracked symptomatic disease. So what we still don't understand is whether or not these vaccines will prevent infection or just disease. So if somebody, for example, develops immunity to getting sick, they may still potentially be infected and can become a carrier, or not a carrier necessarily, but can actually become acutely infected, not be sick, and could transmit to others. We don't know if that's the case or not with these vaccines yet. And of course, that will be something that many of us will be trying to study in the days and weeks to come. And the other issue is the durability. We do know that these vaccines produce neutralizing antibody, but to what degree that neutralizing antibody lasts and what titer of antibody is needed to protect is unclear at this time, and that will also be studied over time. If we know what the record is for coronaviruses, it is that coronaviruses cause reinfections in humans, so it's possible that there will not be permanent immunity and there may be boosters necessary, but we don't know that at this time.
Great. One last question. Do you have suggestions of how we can communicate to our staff and patients about the safety of the vaccine and alleviating fears?
Absolutely. So we here at our institution, and I'm sure many of you are doing this as well, are currently putting together town halls and FAQs and lots of conversations and posting on our websites so that as soon as the data becomes available, so that we can reassure our communities that these vaccines are safe. Now, first of all, we need to see the data ourselves. And we were very clear from the very beginning, meaning the Academy was, that we needed to see the data, it needed to be transparent, and we needed to be able to judge for ourselves what we were, what these vaccines safety profiles were and efficacy profiles. And so we have seen that data. We will continue to look at it in the next week or so. And I think that the more we can look at this data and get involved with our communities to give this information out and work through our, again, your local chapters in particular, but actually nationally AAP is also going to be messaging quite strongly about these vaccines as they come out. So I do think this is an evolving process, and it'll be really a challenge to get the word out, because we know there's a lot of misinformation and mistrust, but we know that people really still trust their medical providers, and we always live up to that trust. So that would be really important for us to get the messages out to you as we're doing tonight.
Wonderful. Thank you very much. Let me turn it over to Dr. Ball.
That was wonderful. Thank you so much. And I have the pleasure of introducing our next speaker, Dr. Peter Szilagyi. He is a professor of pediatrics, the executive vice chair of the Department of Pediatrics and the vice chair for clinical research at UCLA. He is one of only 15 voting members of the CDC's Advisory Committee on Immunization Practices, or the ACIP. And like Dr. Maldonado, is also a member of California's Vaccine Scientific Safety Review Work Group. And I am pleased to welcome Dr. Szilagyi to speak on patient prioritization and logistics for the COVID-19 vaccines.
Thank you very much, Eric, for a nice introduction, and that was a great talk, Dr. Maldonado. Can I just check in, do I have my screen, fully enlarged here?
Dr. Szilagyi, will you hit the display
Oh, the
settings
display,
again? Like
there we go.
Thank you.
How is that? Is that better?
That's better.
Okay. Well, thanks. This is it's a great opportunity to be speaking with you. I've spoken before the Immunization Coalition before, but on HPV vaccine and never on COVID vaccines. This is going to be a bit of a practical talk. I've been asked to talk about the patient prioritization and the logistics for the vaccines. And what I'd kind of like to do is to get you into the decision process or how to allocate and prioritize the vaccines and some of the logistics that we've gone through. I don't know if I needed this, but I don't have any disclosures except I borrowed a few slides from CDC. So on ACIP, we've used three main principles to decide on allocating who gets the vaccines first and who goes next. One is science, looking at the disease burden from the virus and the benefits and harms from the vaccine. The second principle or domain is implementation, the feasibility, as well as the values of the target group, and I'll be talking about these. And the third, which we spent a lot of time on, 6 months on, is ethics, how to maximize the benefits and minimize harms, promoting justice, and I'll talk about this, mitigating health inequities, and promoting transparencies. So I'll have a little bit more on this, but as you've all heard, there are 4 major priority groups. Healthcare personnel, 21 million. They're part of the essential workforce, which is a total of 87 million. Individuals, adults with high-risk medical conditions that place them at risk for COVID disease, and that's 100 million. And adults over 65, that's 53 million. There's actually a lot of overlap. Something I learned just yesterday, half of essential workers actually have high-risk medical conditions, and 16% are over 65. So there's a fair amount of overlap in these groups. And then I'll talk a little bit more about the phased sequence and the possible phase sequence. So we'll hear more about that a little bit. So as Dr. Maldonado kind of mentioned, these are some of the priority groups. Healthcare personnel, 21 million. Here's a list of individuals. You all are one among them, among the pediatric community who's listening. Essential workers, this cuts across a very large part of the workforce in America. Adults with high-risk medical conditions, obesity is by far the most common, diabetes, and you can see the other conditions. And then adults over 65 years of age, with about 3 million adults in skilled nursing facilities or assisted living facilities. So these are the priority areas that we went through in terms of figuring out who should go first. Now, CDC did some really elegant modeling about the potential impact on preventing infections and death. In other words, if you allocated first to one group before the other, would you prevent more death, more infections, or not? So if you look on the left side here, this is the percent of infections that are averted by first vaccinating. So what happens if you vaccinate older adults over 65 first? You prevent maybe 22%. High-risk adults, essential workers, and what you can see is that there's not much of a difference. Vaccinating high-risk adults or essential workers first averts a little bit more, maybe 3% more infections. If you look at deaths, here on the right side, vaccinating over 65-year-olds averts a little bit more deaths. The bottom line is that the differences among prioritizing the 3 groups are rather minimal. And the largest impact is to get these vaccines out as early as possible. So given the fact that there weren't that many such large differences, other factors are going to play a key role in who gets the vaccine first. Vaccine effectiveness in older adults, and we heard Dr. Maldonado talk about that a little bit, with high effectiveness for the Pfizer vaccine. Whether the vaccine can prevent asymptomatic infection and transmission, we need to continue our masking and social distancing, and really importantly, ethical principles and decisions are going to have to play a major role. So we looked at 3 components of ethical principles: how to maximize benefits and minimize harms, promoting justice, and mitigating health inequities. So for healthcare personnel, for example, there's a multiplier effect. If you protect healthcare personnel, you preserve healthcare capacity. Promoting justice, healthcare personnel, we're all putting ourselves at high risk because we're exposing ourselves to COVID, although we were wearing protection. And mitigating health inequities, people may not know, but among the 21 million healthcare personnel, most of whom are not doctors or nurses, a very high percentage are low-wage earners and racial and ethnic minorities. And then we went through a similar process with long-term care facility residents, and putting all that together, prioritize them first. And then I won't go into great detail here, but we spent months looking at who should go next after the healthcare personnel and long-term care facility, assisted facility residents. And here on this slide, I show essential workers, adults with high-risk conditions, and adults over 65. Dark green is what we thought shows the most, kind of the highest level of evidence from the ethical principle. So essential workers kind of won the day in terms of maximizing benefits with a multiplier effect and keeping society going, promoting justice because they have to work. They can't work at home, they have to work at work, and mitigating health inequities because a very large percentage are minorities. And this kind of was one of the major decision factors in now recommending essential workers next. And then adults with high-risk medical conditions and older adults are going to go next. So, as many people have said, vaccines don't save lives, vaccinating saves lives. So will target groups be willing to be vaccinated? So I've been leading a study, a national survey of US residents. It's part of the Understanding America study, which is a probability-based intranet panel representative of the United States. We have about 6,000 respondents, and every 2 weeks, we've been asking if a vaccine against the coronavirus becomes available. Actually, we ask a slightly different question, but in October and November, we asked, if it's available, do you plan to get vaccinated? Yes, ASAP, yes, wait and see, no, but wait and see, no, or unsure. And then we asked a couple questions about trust in the government approval process and trust in the vaccine process in general. And here are the results, and you've been hearing about this from other surveys, some of which are actually convenience samples and not representative. But the results are a little bit concerning. So I have here in green, dark green means yes, I want to plan to get vaccinated ASAP. Light green is wait and see. And the reds are no, and the orange is unsure. So for all Americans, about 55% say just a few weeks ago, they plan to get vaccinated. Females are less likely. I'm happy to see older adults say that they're more likely. Those with college degrees or those without college degrees are far less likely to say they're going to get vaccinated. And then African Americans are extremely unlikely to, they say they're very unlikely to say they're going to be vaccinated. And that's really concerning because they're at one of the highest risks from COVID disease. Interestingly, here's the healthcare workers, only about 60% say they're likely, and it's not very much different from the others. And in those with chronic disease, maybe slightly more likely. And then when we asked, do you trust the government approval process? It's almost like a mirror image of the prior slide, isn't it? So only about a third, maybe 40% really trust. Then there's a lot that somewhat trust and a lot who do not trust. And it really seems like trust is at the heart of wanting a vaccine or not. Another concerning finding for us is, remember I've told you that we've been measuring this every 2 weeks. The percent of individuals who say they're likely to get a vaccine has gone down from April. And when we did that big survey, it was in October, to about 60%, as I mentioned. It went up a little bit after the election, and now it seems to be slipping again. So will target groups be willing to be vaccinated? There's a lot of hesitancy and a lot of wait and see, and trust appears to me to be the underlying factor. So effective communication strategies are going to be critical, as Dr. Maldonado talked about. We need to have a coordinated strategy, which is really being developed. They have to be culturally tailored. There's going to be a really, I think, an important role of these safety work groups. So for example, the California or the Western State Safety Review Group, I think the major purpose for this group is another set of expert eyes reviewing the efficacy and safety of the vaccine. And I hope that multiple sets of eyes and recommendations will reassure the public. The other thing is that I do think that because we've seen a change in hesitancy, vaccine hesitancy, I think for COVID is mutable. And so that means that with proper communication, I think we could really maybe raise a percentage who say they're going to get the vaccine. But it's not going to be near 100%, I'm convinced. The other point that I wanted to make is that the role of the primary care provider. Studies have really shown that people listen to their primary care provider. Parents listen to the pediatricians. And so it's going to be exceedingly important for us. Even though the vaccines are initially for adults, we're seeing parents, we're seeing adults, they're going to be asking us about whether they should get a vaccine. So as Dr. Maldonado said, here's the sequence. And here's a slide I put together. Don't hold me to this, but I did put dates on here. And so phase 1 is going to kind of happen like this. But after several weeks, I think we'll be starting to vaccinate phase 1B. So this is healthcare workers. This will likely be essential workers. And then chronic disease in over 65, somewhere around here. Then we get to phase 2 to other adults. And I'm going to skip this because Dr. Maldonado talked about this. So healthcare workers, so who are the healthcare workers? What's going to happen in the next few weeks? Across California, there's 2.4 million healthcare workers. This is where they are. So we are in the other category for most pediatricians. The first allocation is going to be at, I think, around 327,000 doses coming out for initially in California. And then California is hoping to get another 1.7 million doses near the end of December, going to healthcare entities and multi-county entities. And I have a few more slides. California Department of Health has described a sub-prioritization. So within healthcare workers, who's going to go first? Now, don't forget the important point here. It's only going to be a couple of weeks between those who go first within healthcare workers and those who go later. But the sub-prioritization can go by type of facility, location of the, and attribute of the individuals. So for example, the health department is suggesting tier 1, the very first group who's going to get the vaccines are these, acute care hospitals, and then tier 2 are these, and then tier 3. So primary care clinics, for example, are in tier 2. In terms of location, there is a plan to send more of the vaccines to facilities that serve the greatest percent of vulnerable people. And they're going to be using a social vulnerability index. And in terms of attributes of individuals, if individual doses within a facility are limited, there are ways to try to prioritize within groups, potentially by age or other attributes. And this gets really, we may want to talk about this in a question period, but this gets really, really complicated. So the University of California, for example, has drafted a priority allocation plan that's going to go like this. In group 1, frontline workers with close, prolonged, repeated exposure, and then frontline workers without prolonged and repeated exposure, those with some risk, and then high traffic areas. But again, this is all going to be within several weeks. And my final, almost final slide is I just wanted to point out there is a very robust safety monitoring mechanism for these vaccines. Dr. Maldonado talked about this a little bit. So one interesting thing, very cool program that CDC has set up is called V-Safe. Healthcare providers who are going to go first, the 21 million, are going to be asked to enroll in this program where we will be, it's a text messaging interactive program where frequently, initially every day, we're going to be asked about our symptoms after a vaccination. If there appear to be side effects, CDC will investigate it and try to determine whether there are any adverse, sort of safety concerns. So just think about this. Within weeks, we're going to have millions of people potentially enrolled in this program and following potential adverse side effects. There's large data programs that are also available. The VAERS, you're all familiar with the passive surveillance program, VAERS. There's also the Vaccine Safety Data Link, a large data set where they're going to be looking at potential signals of significant adverse events. And the CDC has done, I think, a very nice job hooking together multiple other large data sets or systems or health systems to try to monitor what happens after individuals get the vaccine. And then my last slide is just some other key considerations like sub-prioritization within categories. Storage and handling is going to be a real key practical consideration because of the requirements for storage and the low temperatures. As Dr. Maldonado talked about, we're recommending 2 doses, either 21 days apart or for Moderna 28 days apart. So how is that going to happen? There's going to have to be sort of a reminder system. They're going to be making use of this of the registries, state registries, for tracking. And I think that's going to open a whole new world for registries, because registries haven't been tracking adult vaccines very much. Communication, as was mentioned with one of the questions, is going to be super, super important. And then there's other really important considerations like outreach to high-risk populations. I don't think there's going to be gaming of vaccine allocation initially. Just between the 600 of you and me, I'm a little worried about gaming potentially when the vaccines start going out in multiple areas. You know, one of the things that we've really tried very hard in public health is to try to make sure that rich people don't necessarily get the vaccine because they're rich, but that we allocate the vaccines to those who need it the most. And so we're going to have to be kind of monitoring the system to try to prevent gaming. There's all sorts of issues with new populations when adolescents and children come in, and Dr. Maldonado is certainly an expert at that. And then we have to be very clear that even though we're starting to vaccinate, we have to maintain masking and social distancing. And finally, I think it'll be interesting to look at the impact on vaccination delivery in general. There's a lot of hesitancy for COVID vaccine right now, more hesitancy than there is certainly for childhood vaccines. And so it'll be interesting to see what happens with COVID vaccines and how that will flow into hesitancy for vaccines in general. So thank you very much. I look forward to any questions, and I'll take the easy questions, and then please give the difficult ones to Dr. Maldonado.
That was great. Thank you so much. I will, all right, I'll start with an easy one. So I think the most common question that we received prior to this was about educators. So we are, you know, trying really hard to keep our kids in school, even though we're shutting down everything else. And was there a thought in prioritizing the folks who work in our school systems?
They're in the group of essential, that's a really good question. They are in the group of essential workers. There's been debate about how states or localities will roll that out. But my understanding is that they're within the 87 million. And so they're going to be going very, very soon. You know, the issue about schools is so important because as the AAP the AAP has been unbelievable with the communication about COVID, including the impact, and I think somewhat the devastating impact on many children, particularly low-income children. And so we really have to work very hard to try to maintain in-person schools as much as possible. Europe is doing this. I know there was a problem in Israel, but there were exceptions. There were exceptional situations with that difficulty in Israel. But Europe has kept schools open even as they had stay-at-home orders in multiple countries in Europe, and they have not had that much difficulty. You know, and I think one of the issues in terms of maintaining schools open, one issue is vaccinating teachers, but another issue is providing the funding for schools so that they can keep children and teachers protected. And that includes anything from ventilation to being able to maintain all of the cleaning and all of the other issues that need to be done by maintaining schools. But essential workers, in my mind, do include teachers.
So I have a very basic question. Where will I receive my vaccination? And I don't mean my arm. I mean, like, where will I get it? Where will my wife, who's a regular person, get it? Where will my kids get it? I'm a primary care pediatrician. I don't have a 70 below zero freezer in my office. So logistically, who's going to do all this?
Yeah, you know, I actually don't know the answer to all that. Initially, with the Pfizer vaccine, there are no primary care offices that I know of who have refrigerated freezers that can go down to -70 degrees Celsius. They're going to be hubs, hospitals. There are actually across the country mobile hubs where this can be delivered. The LA County, for example, is basically putting in testing sites or outdoor. They're creating these outdoor facilities where mass vaccination will occur in outdoor areas, kind of similar to the way mass testing has happened. So, and then pharmacies. There's large connections with pharmacies that are able to store the vaccines. Don't forget, the vaccines don't have to be, they can be out of those that deep freeze for several days, maybe even up to 5 days. But so I don't know whether it's going to be easy or possible to then take them out and sort of for a very short amount of time send them to physicians' offices. And I haven't seen yet in California a very clear plan for exactly where everybody should get it. And you know, and initially healthcare workers, it's going to be hospitals, potentially pharmacies, or potentially the local health department sites, which are like going to be like hubs.
So when we look at the way,
do you have any other information about this?
You know, I'm similar. I think one of the ideas that has really come up is the pharmacies. You know, many of the chain pharmacies, I think 70 to 90% of the US population lives within 10 miles of one of the chain pharmacies that we all know about. And so those will likely be a very important source of vaccination, I think, for the general population. Because they are, I've been on the National Vaccine Advisory Committee in the past, and they are very vocal supporters of pharmacy-based, commercial pharmacy-based vaccination. And this is where this registry idea is important, because we need to make sure that we track that. As you know, the Academy has had a mixed reaction to that issue of pharmacy-based vaccination for children, because we need to maintain that medical home. So this will be a really important, hopefully, collaboration with those pharmacies.
And do you remember that last slide that I had where I talked about the potential kind of spillover, either benefits or negative impacts? That's what one of the things I was referring to for other vaccines. As American adults get vaccinated in pharmacies, you know, what we have to be really careful is that there's not a major shift. I think we have to be careful that there's not a major shift for other types of vaccines going away from primary care pediatric offices, for example, to pharmacies. Right now, there is an increased number of children and adolescents who are already vaccinated in pharmacies, but the vast majority are vaccinated for regular vaccines in pediatric and family medicine offices, and I really think it should stay that way.
So every few days in the United States, like 1 million people get COVID now and theoretically drop out of that susceptibility pool. So are we going to not vaccinate the people who have already had COVID, or vaccinate them later? Or will we just do everyone right off the bat?
Yeah, that's a good one for Dr. Maldonado, who's one of the experts at this.
Yeah, so I actually, just by chance, I was teaching an epidemiology class to the PhD students here when COVID hit, and we were modeling the disease. And you actually probably know this, but you're going to need about 50 to 70% of the population to have immunity in order to develop enough herd immunity to prevent real widespread transmission. And right now, surprisingly enough, even though we're seeing these many cases, the seroprevalence data suggests that the average seroprevalence across the country is probably about 3 to 5%. It's just that we're seeing very large pockets. And so I do think that there will be a need for vaccine across many populations. We're actually trying to make that decision right now in our hospital. And because CDC and others have demonstrated that the risk of reinfection appears to be low within the first 3 months or 90 days after infection has been documented, natural infection, that likely people who are within 90 days of infection may be at the back of the line for immunization. It doesn't mean that we shouldn't immunize those individuals, but at least at the beginning, probably those people who are recently infected may want to wait at least 3 months. But obviously the numbers are not hard and fast. I've been looking at a lot of antibody data from studies here we've been doing at Stanford, and it is really amazing how variable the neutralizing antibody response is to this vaccine and help in individuals to natural disease. So you can see people who have been infected who have 0 neutralizing antibody titers at all within a week or so after infection, and others who have very robust titers. So it's not clear yet who will have those antibodies. Now, we don't have the capacity. As you know, the Academy and CDC generally don't recommend getting serologic titers before you vaccinate. So we'll probably just go with some general guidelines until we have more information.
So they will, but they kind of push toward the end of the line. But you can see with that modeling of, whether it is 50 or 60 or I think it may need to be 70% vaccination to really start to get herd immunity. You can see why I'm so worried about the data that suggests that only maybe 50, 60% of the US population may want this vaccine. So this, I think, leads us toward how important it is to communicate the benefits, the safety of the vaccine. And by the way, it's one of the many, I didn't talk about this, but one of the many reasons that healthcare personnel were kind of pushed at the beginning of the line. There were many other reasons, but many of us thought that actually eventually a higher percentage of healthcare personnel will get this vaccine. And that will encourage others to get the vaccine. There is some evidence in the regular vaccine literature that as we tell our patients, I got the flu shot, everybody in my pediatric practice got the flu shot, that encourages our patients, our parents, to want their children to have a flu shot. And I'm hoping a similar type of thing will happen with COVID vaccine. And I'm hoping that, that graph looked terrible about the percentage of healthcare workers who say that they're going to get a vaccine. I was seeing patients just yesterday, and in clinic, several of the nurses were kind of concerned about the vaccine, but after talking, by the end of our conversation, they weren't as concerned anymore. So I think that percentage is going to go up, and I hope it'll encourage a much higher percentage of the US population to really want this vaccine.
I want to ask you one last question based on that. So one thing that we've done with the AAP for flu vaccines is we've encouraged people to take pictures, take videos of yourself getting flu vaccines, show it to your patients, post it on social media if you feel comfortable doing that. And, I know in my office, people don't ask me generally, should I get the COVID vaccine? They ask me, are you going to get the COVID vaccine? And I'm curious what you think about all of us, because by the time we have our next COVID conversation in January 13th, a lot of us will have been vaccinated by then. I'm curious your thoughts about us leading the charge and leading by example.
I think that's really important, Eric. And I think we should lead the charge. I was delighted to hear that Presidents Obama and Bush and numerous kind of luminaries have said that they would be willing to have themselves videotaped while they're getting the vaccine. And I think that will be important. I think it will be really important for minority populations to be seeing, people who are like them. So Black individuals, Latino individuals, Native American individuals, to be seeing, their heroes and heroines get vaccinated. And similarly, one of the heroes, the heroes and heroines for many people are physicians. And so I think what you're saying is really important. And I'll be, with a bullhorn telling people that I got my vaccine. I'm not going to be very first in line because I think University of California is going to prioritize a few other people first because I'm just a primary care pediatrician and I'm not in the ICU or the ED. But I'll be soon after, and then I'll be on the bullhorn telling people that I got the vaccine.
Well, we want to thank both of you for joining us tonight. This was fantastic. There are a million more questions that are out there, and some of them will be answered at our next one, which will be January 13th. It's going to be all about logistics. These are the guys who are actually building the way that we're going to be physically giving people these immunizations in California. So join us on the 13th with Dr. Brooks and Dr. Schechter. The registration link is now active, so you can go to the California Immunization Coalition website and sign up for that. And then after this is over, we're going to email out an evaluation for everyone. It's really important that you fill out that evaluation. It gives our speakers feedback, but it also gives us ideas of what you want us to talk about in the future. And one of the things we're going to ask in the evaluation is, do you plan on getting the COVID vaccine? And we'll publish that for everybody who is here just as a little informal poll. And finally, I want to thank all of you, not just for joining us today, but for everything you do. People on this call are physicians who are taking care of these patients. They're educators who are, keeping our kids in school, public health workers who are doing the hard work to keep us all safe, and people who are building these vaccines, which are going to save us all after this. So thank you for what you do. Thank you for joining us, and we look forward to seeing you in January. Thanks so much.
Thank you. Bye-bye.